Hello guys, how are you? I hope so that you will be fine. Today I have selected a topic on adenoids. So let us discuss what it is. The most common bacterial pathogen cultured from adenoid specimens are Haemophilus influenzae, Streptococcus pneumoniae, Streptococcus pyogenes, and Staphylococcus aureus. Chronic adenoiditis is more often a polymicrobial infection and may include anaerobic pathogens. Chronic adenoiditis frequently results from biofilm development and may contribute to recurrent upper respiratory tract infections in children. In most cases of pediatric rhinosinusitis, adenoiditis is involved as well. Allergies are believed to play a role in adenoiditis and subsequent adenoid hypertrophy. Allergens inhaled through the nose come in contact with adenoid tissue. The adenoid will then proliferate in order to create a response to allergen and produce IgA. Chronic irritation from stomach acid in the setting of the gastroesophageal reflux GERD may also play a role in adenoiditis and adenoid hypertrophy, particularly in infants and young children. Adenoitis is usually addressed in the context of a regional disease process such as rhinosinusitis and adenotonsillar disease. Since adenoid tissue atrophies during puberty, adenoitis is typically a disease in children. Current literature does not suggest a predilection for gender, race, region, or socioeconomic class in this disease, though parental smoking has been positively correlated. Adenoitis can be challenging to differentiate from bacterial sinusitis in children. Therefore, statistics on sinusitis in children may give us some idea of the frequency of adenoitis. Estimates are that children have 6 to 8 viral URIs per year. 5 to 13% of these viral URIs, upper respiratory tract infections, result in bacterial superinfection leading to sinusitis, with adenoitis as a potential component of the illness. Acute adenoitis often occurs after a viral upper respiratory tract infection (URI), and bacterial agents proliferate and infect the adenoids and surrounding tissue, resulting in inflammation and increased production of exudates. Symptoms include rhinorrhea, postnasal drip, nasal obstruction, snoring, fever, and halitosis. Chronic adenoiditis shows many of these same symptoms but on persistent basis, lasting at least 90 days, and is often caused by polymicrobial infections and biofilm formation. Exudates are frequently absent in chronic adenoitis. Another cause of adenoitis is environmental allergens or caustic irritation from stomach acid in the presence of GERD or LPR. Any form of chronic inflammation may lead to proliferation of lymphoid tissue and subsequent adenoid hypertrophy. This hypertrophy can lead to nasal airway obstruction and obstruction of the eustachian tubes, leading to the other problems such as obstructive sleep apnea, OSA, and otitis media. Other causes of adenoid hypertrophy, though not necessarily adenoid inflammation, include primary sinonasal malignancies, lymphoma in human, immunodeficiency virus, HIV infection. Adenoid tissue typically regresses around puberty. Therefore, the typical patient with adenoitis is a prepubescent child with a recent history of upper respiratory tract infection. The patient may also have a history of recurrent acute otitis media, chronic nasal obstruction with mouth breathing, chronic otitis media, sleep-ordered breathing, obstructive sleep apnea, or GERD LPR. Physical findings include purulent rhinorrhea, postnasal drip, nasal obstruction, snoring, fever, mouth breath, and halitosis. An indirect mirror exam may allow the clinicians to observe enlarged adenoids with exudates. Though this can be a very challenging exam to perform in children, a flexible nasal and laryngeal endoscopic exam can allow for better evaluation of the adenoids but can require advanced training to use as well as the cooperation of the child and parents. In rare cases, the adenoid may be large enough that it protrudes downwards and it is visible beneath the edge of the soft palate. When the adenoid is large enough to displace the soft palate, whether acutely or chronically, it is liable to affect the quality of the patient's speech. Long-lasting adenoitis with subsequent adenoid hypertrophy in early childhood can lead to the development of what is known as adenoid facies or long face syndrome. Enlarged adenoids block the nasal pharynx and result in obligate mouth breathing, which can lead to craniofacial abnormalities including a high arch palate and retrognathic mandible. Clinical evaluation. Now, the diagnosis of acute adenoitis is made clinically based on the findings of possible concurrent otitis, acute otitis media, fever, purulent rhinorrhea, postnasal drip, nasal obstruction, throat pain, halitosis, and visual inspection of the adenoids may be attempted using a laryngeal mirror or nasal endoscope. Laboratory testings, rapid strep test, and cultures, allergy testings are being done. If adenoiditis represents in the context of pharyngitis, the clinicians may perform a rapid strep test. The purpose of doing is twofold. First, this will give a definitive diagnosis of the patient's condition and help guide antibiotic therapy. Second, the doctor office will have a record of the positive and negative strep test. which will play an important role when deciding whether an adenoidectomy with or without tonsillectomy is indicated. It is important to remember that adenoitis remains a clinical diagnosis, so if the strap test is negative, the physician can presume that symptoms are due to a different causative organisms. In cases of persistent infection despite antibiotic therapy, the clinician may choose to perform throat cultures to help identify the causative agent and guide treatment, as direct cultures of the adenoids may be difficult in the office settings. Other tests to consider include a complete blood count and HIV testing. If the adenoiditis is believed to result from a seasonal or environmental allergies, skin testing may help direct therapy. Radiology testing, lateral neck X-ray being done, and computed tomography CT of the sinuses being done. X-rays, sinuses, or sinus CTs may be obtained to look for a source of infection in the sinuses. If this is suspected clinically, this is really required in routine cases. Lateral neck X-rays are an effective way to evaluate this specifically for adenoid hypertrophy. A deep sleep study can be obtained to rule out obstructive sleep apnea in a patient with adenoid hypertrophy who snores. Then adenoitis is often seen clinically as a component of rhinosinusitis or pharyngitis. Because of this, healthcare providers often follow clinical management guidelines for rhinosinusitis and pharyngitis when approaching adenoitis treatment. What is medical treatment observation? If the clinician believes the cause of adenoitis is the common cold or other common viral infection, they should refrain from using antibiotics. Typically, uncomplicated upper respiratory tract infections will resolve within 5 to 7 days. Antibiotic treatment, if some symptoms continue or clinical presentation is suggestive of bacterial etiology such as high fever or purulent discharge from the nose or throat, the first line management is antibiotic covering the most common pathogen. Amoxicillin is commonly used first line agent due to its good coverage and minimal side effects profile. Augmentin is being used. Alternatively, Savdenavir or cefuroxime may be used, particularly if the patient has not responded to amoxicillin. If the patient has penicillin allergy, alternative include clarithromycin or azithromycin. Effective antibiotic treatment should improve symptoms in 48 to 72 hours. Treatment duration should be 10 days, as treating for a shorter duration yields significant relapse rates and breeds antibiotic resistance. If the condition fails to improve after a course of amoxicillin or other first line agents, amoxicillin clavulanate augmentin should be prescribed to eliminate potential beta-lactamase producing organisms. Saline sprays and nasal rinses may also shorten the duration of symptoms by irrigating out the causative microorganism and the stagnant mucus secretions that may harbor them. Then, if the adenoitis is believed to be secondary to environmental allergy, the patient can be given a trial of nasal steroid sprays, oral steroid, oral antihistamines, or some combinations thereof to see if this produces any relief in symptoms. If this is effective, the patient may benefit from formal allergy testing followed by immune modulating therapy to provide definitive relief. Saline sprays and nasal rinses may also play a role in these cases. If adenoitis is believed to be secondary to LPR or GERD, treatment of this condition using lifestyle and diet modification and elevation of the head of the bed, with or without the use of H2 blockers or proton pump inhibitors, may provide sufficient relief of symptoms. Surgical management is adenoidectomy in the absence of symptomatic improvement or after treatment with amoxicillin clavulanate, or if the patient has multiple episodes of adenoitis requiring antibiotic treatment, referral to an otolaryngologist is warranted for further evaluation and potential surgical intervention. Depending on the circumstances, surgical procedure may include adenoidectomy with or without tonsillectomy, myringotomy with the tympanosotomy, tube placement, or endoscopic sinus surgery. If the patient meets the Paradise criteria for tonsillectomy, most otolaryngologists will remove the adenoids at the same time to remove another possible source of recurrent infection. Similarly, most otolaryngologists will remove the adenoid. The patient require repeat tympanostomy and placement of pressure equalization tubes after the first set due to the potential for adenoid hypertrophy to cause chronic eustachian tube dysfunction. What is the differential diagnosis? Differential diagnoses include viral upper respiratory tract infections, sinusitis, rhinosinusitis, nasal polyposis, pharyngitis, tonsillitis, seasonal environmental allergies, nasopharyngeal neoplasms, laryngopharyngeal reflux, lymphoma, or HIV. The medical treatment available for treating adenoitis is successful in most instances. Adenoidectomy provides a definitive solution for those with recurrent disease by recovering the hypertrophic or infected adenoid tissue. What are the complications? If adenoid adenoiditis is left untreated, the patient may develop chronic infection of the adenoids, which in some cases can lead to the development of biofilm. The adenoids may then serve as a nidus of infection for other closely related structures and lead to rhinosinusitis, pharyngitis, tonsillitis, and otitis media. What is adenoid hypertrophy? Adenoid hypertrophy is responsible for some of or the more common complications related to the disease of adenoid. As the adenoid enlarge, the tissue can create a significant obstacle to flow of air through the nasopharynx. This enlargement can cause mouth breathing, snoring, and OSA. Obstructive sleep apnea can be life-threatening disease if left untreated and can interfere with cognitive, emotional, and behavioral development in children. Removing the adenoids can increase the flow of air through the nasopharynx, decreasing obstructive episodes and leading to better compliance with continuous positive airway pressure devices and oral appliances, or even resolution of the OSA altogether. Enlarged adenoid may also obstruct the opening of the eustachian tubes in the nasopharynx, and without proper function of the eustachian tube, negative pressure can escalate in the middle ear, which can lead to tympanic membrane retraction and development of an effusion in the middle ear or a mastoid cavity, which can cause conductive hearing loss and speech problems, as well as serve as a nidus for bacterial infection. Long-lasting adenoiditis with subsequent adenoid hypertrophy can lead to development of what is known as adenoid facies or long face syndrome. Enlarged adenoids can obstruct the nasopharynx and result in obligate mouth breathing, which may in turn lead to craniofacial abnormalities, including high arch palate and retrognathic mandible. The conclusion is that the patient with recurrent adenoiditis or complications of adenoid hypertrophy should be referred to otolaryngology for further evaluation and treatment. Other specialties that may need to be involved include sleep medicine, allergy immunology, and gastroenterology, depending on the individual needs. Adenoiditis is a common issue in children and may be unavoidable since they are frequently in contact with the common pathogens and allergens that cause upper digestive tract inflammation. However, it is essential to seek treatment before chronic adenoiditis and adenoid hypertrophy develops, as these can lead to complications that may decrease quality of life. Adenoiditis is a condition of childhood, and most adenoid tissues atrophies by adulthood. Adenoiditis is a seldom solitary tissue. It is usually a part of indistinguishable from adenotonsillitis, rhinosinusitis, or pharyngitis. Adenoid hypertrophy is responsible for the most common health issues associated with adenoids. Obstructive sleep apnea is one of the most serious complications of adenoid disease, and surgical adenoidectomy is the definitive treatment for adenoid disease. Because causes of adenoiditis include various clinical entities such as recurrent bacterial infection, allergies, GERD. Treatment of adenoiditis and its complications may require the care of multiple clinicians and specialists, including family physicians, clinicians, ENT practitioners, pediatricians, and infectious disease specialists. These specialists should collaborate closely with nurses and pharmacists, doctors as an interprofessional team to optimize patient outcome. Identifying and addressing the underlying etiology is essential, or the adenoiditis may never fully resolve and progress to further complications. Healthcare team members should pay close attention to the signs and symptoms of OSA, and this is one of the most serious complications of adenoid disease. So this was all about adenoid disease. I hope so that you would have liked this video, and if you have liked this video, then share this video with other individuals as well, and kindly subscribe to my channel. And thank you for listening this video, and have a wonderful nice day. Thank you very much.